Good evening and welcome to Medicine in Our Backyard. Our speaker has just arrived, and so those of us who are united in back pain are happy to see him. So this is a series that's presented by the Newport Beach Public Library Foundation in partnership with UCI Health. My name is Adrienne Windsor. I'm a board member emeritus and a great lover of medicine in our backyard. We'd like to thank our generous sponsors, Mike and Polly Smith. We'd also like to thank UCI Health. And we would like to thank, this is our last meeting, Kunga, our program director, and Jane Merritt with UCI Health, because they put this program together for us. So we have the privilege of being a membership foundation. We are membership driven, and our mission is to support the library and fund valuable library resources, services, and stimulating programs to the community. Can I see a show of hands? How many are members? All right, that's great. And we have two wonderful members with us tonight. I hope you know that we are going to have a new Whitty Hall. You see the construction, the destruction of the construction that's going on outside every day. And we have Bill Whitty and Kiko with us tonight. Would you stand up? Oh, all right, just wave. They are the benefactors of that Whitty Hall. It's named for the Whitty family, and we have a very special celebration coming up on June 12th, and this is our summer solstice. We are going to be welcoming new members, so I'm saying to you tonight, if you join by May 27th, you can come for wine and hors d'oeuvres, and you get to meet all these wonderful people who are members of the foundation. You get to meet the board, you get to meet some of our major donors, and you get the opportunity to hear an award-winning photographer, Stuart Paley, who has covered wildfires, and the invitations are fiery orange. And you feel like you want to put them out with flame retardant. So join by the 27th, get one of these orange invitations, and become a part of this group. But the other thing I wanted to say is that at this celebration, we will be honoring Jean Whitty. And Jean founded the Whitty Lecture Series with a gift to honor her late husband. And the Whitty family has been sponsoring the Whitty Lectures for how many years now? 27 years. And that that so enriches our community. So anyway, become a part of us if you aren't. The program will conclude with Q&A, so save your questions until the end. And I know our speaker is very generous with his time on answering your questions. And if you haven't silenced your phone, do it now, please. So let me introduce Dr. Sohaib Hashmi. He's returning to us. He was here a year ago. He came a year ago and he told us how to get rid of our upper back pain, and we all said, we have lower back pain. So he has returned. He earned his medical degree at the University of Toledo College of Medicine and Life Sciences in Toledo, Ohio, which is about 20 miles away from my hometown. So we became great friends last time as we reminisced about the Midwest. He completed a residency in orthopedic surgery at Northwestern, Feinberg School of Medicine, and McGall Medical College Center in Chicago, followed by a fellowship in orthopedic spine surgery at the University of Maryland Medical Center in Baltimore. He received fellowship training in orthopedic trauma at Cedars-Sinai Medical Center in Los Angeles. And he's going to be talking to us tonight about helping us with our back pain. So help me welcome Dr. Hashmi.
Thank you so much for that warm introduction. It's great to be back. I can't believe it's a year later. Hopefully all of our neck pain is totally gone and solved. This is just the final, so we'll bookend it, I guess. And today we'll talk about back pain, and hopefully some of these concepts can be really clear about really understanding where the pain is coming from and the symptoms that it gives. Back pain can be very, very hard to diagnose, and I hope if we take just one thing away, it's the diagnosis that matters the most. And so figuring out what the symptoms are and what the etiology or the cause is usually the number one step of figuring out what the back pain is and how it started. So back pain is exceptionally common. Actually, if we look at all visits to healthcare providers in the United States, top 3 most common complaint is back pain. So usually everyone in their lifetime will see one of their providers for back pain, whether it's in the clinic or whether it's in urgent care or the emergency department. I think one of the things that we really want to stress is we want to keep patients out of the urgent care and emergency department for back pain, is that we really want to get it under control so that you don't have to spend hours and hours ever waiting in the emergency department to take care of back pain. Now, some back pain, and we'll go through some of it, is very urgent and would potentially need an urgent evaluation. So some of those symptoms we'll go through. And those symptoms, some of you have probably heard of as red flag symptoms or bowel bladder changes and incontinence, and I'll explain how that can come about. That overall, thankfully, is exceptionally rare. The other good thing is that although I'm a spine surgeon, 80 to 95% of my patients will never need a back surgery. And so 90% or so, I would say, of the patients that I see will never, ever need a spine surgery. And the ones that do, we'll talk about the advances in treatment. Some of the changes that we see in spine surgery over the last few years, even the last 4 years, are exceptional. Patients almost go home. Today, for instance, we had a surgery that was a 3-level surgery in the lumbar segment, and the patient went home 4 hours after the surgery and is home now. So it changes that we can't even fathom, even 3-4 years ago, as patients would stay overnight or for a few days, have physical therapy, have bracing. And all of that has really changed as we brace patients almost never if they need a surgery. We get them up and moving the same day. So when patients rarely need a surgery, we have huge advances that we'll touch on. I'll go through all of these slides, and then in the Q&A especially, please let me go back to any slide that you have questions about. So keep that in mind or take a note, and we'll go back to these slides. This is really interesting. So I want to talk to you about the back pain that causes so much discomfort. Actually causes more than just a physical and functional discomfort. And this is a score that we use in our research studies called the PROMIS scores. And it's one of the scores that we've become more keen on understanding. And it's overall in an umbrella of study metrics called patient-reported outcomes, or you may have heard this PROs for short. So patient-reported outcomes are more important now as we study back pain, and especially the treatment of back pain, than ever before. Meaning, when we did studies for the past 4, 5, 6 decades, we always focused on radiographic parameters. We said, this patient had this x-ray before surgery, and then they had surgery, and this is what their x-ray looks like. But guess what? We don't treat x-rays. We don't do surgery for x-rays. We do surgery and treatment for patients. And so finally now, in 2024, we understand that the patient-reported outcomes probably have the most significant impact on which treatments work well and which treatments don't. And if you look at the patient-reported outcomes, just PROMIS one of them, you can see how much is covered and how much disability a patient may have in their life, from social function to pain intensity, physical function, fatigue. It goes all the way to emotional health. I mean, back pain is not something that is just physical. It's way more than that. And once it becomes affecting a patient's anxiety and depression and psychosocial health, it can be very, very detrimental overall. So we're finally understanding that back pain is much more than the physical state or the physical disability that patients will have. So it has major consequences. The one thing that I want you to also know is that back pain will be very common as we age, but age is really just a number. So now we have patients, especially in Southern California, that are more active than ever, that 70-year-old, 80-year-old, 90-year-old patients that we see have the same expectations, rightfully so, as our younger cohort, and they want to be just as active. And so treating back pain for every patient is exceptionally important regardless of age. And that's why I say age is just a number, is that the large majority of the changes that we see in our spine are not related to the number at all. They're actually related to genetics. And that's another point that I really hope that we take home from this tonight, is age has nothing to do with largely the degenerative changes, the wear and tear that will happen in our spine. It's the genetics, meaning the genetics will drive most of the changes that we see. So really it's about how you feel. So often patients come and they say, well, doc, what can I do and what can I do? And I say, I would ask you that question, is what do you feel like you can do and what can you not do? And usually when we start with physical therapy, and there's actually probably the highest level physical therapist that I've ever encountered in my life in Southern California, all types of physical therapists that have training in back pain and neck pain, and the psychosocial factors that relate to it. So it's really about figuring out what you feel you can't do and working towards getting there. Is there structurally and genetically really nothing that thankfully we do that will make our back worse off? And that's what I like to make sure patients understand, is there's nothing that as a spine surgeon I ever have felt that patients cannot do, unless obviously it causes you pain. And that's what we need to focus on. Now, some types of pain I'll talk to you about structurally can be dangerous or may be something that we need to structurally look at with a surgery. But that, again, is 10% or less. Okay, so the objectives of tonight's talk, just a few and their overall, hopefully we break them down, is first we have to understand what the common symptoms are of back and leg pain. And everyone, if you've been to a spine provider or your general practitioner, they usually ask about this. They ask about, do you have back pain? Do you have leg pain? Do you have back and leg pain? And I'll show you the overlap. Sciatica is one of the umbrella terms that we think about, and everyone knows sciatica, especially if you've had it, then you know what sciatica is, and you'll never forget. And the patients that have sciatica, they'll always know if the sciatica came back. And so that is something that anyone who's felt sciatica or a nerve being pinched down in their back, going to their legs, knows. But sometimes it's overlapping. It's back pain and leg pain symptoms that can happen. The other thing that I wanted to show you in some illustrations is the structural changes that do happen. For everyone, they're very, very different and largely, again, driven by genetics. And the last thing is how those symptoms and findings have an interplay and what the natural history is, a lot of these things. So let me start with a short case here. So imagine 57-year-old patient, very active, came into my clinic and said, I have really bad pain in the low back, and it really happens only when I twist. I have no leg pain at all. I don't have any leg weakness. I don't have any numbness or tingling. I don't have any bowel bladder changes. I've never had, thankfully, episodes of incontinence. And I really, really feel it if I play tennis or golf and I twist. And they really grab their back just like this. They grab the side of their back, meaning what we call paraspinal muscles, like off to the midline. They'll say the right side hurts more than the left. And usually I can go a full day without having it bother me at all. And so if we look at their x-rays, this is what we find, is the point where they, or the spot where they really hurt is very focal, but off to the midline. This x-ray is showing a lateral view, meaning from the side. So if you took an x-ray of me and looked from where you are, belly would be in the front, and that's just over here, and the back would be here. And what we see in x-rays, which is really, really important, and patients often ask, why in 2024 do we need x-rays if an MRI can tell us way more information? The reason is an x-ray is dynamic. MRIs, although there are some dynamic MRIs, they're nowhere near as helpful structurally as x-rays. So the x-ray of a patient, when you go in to see a spine provider, can tell you the structural anatomy when you're supporting your own weight. And everyone has a very different structure and alignment and weight and muscle mass, and that is more apparent on the x-ray than it is on the MRI. And I'll show you as we get down, the MRI is when you're laying flat on your back, so actually the spine can look much better than it is than when you're upright. So that's why we always get x-rays. And we compare the x-rays to CT scans and MRIs when you're laying on the scan or on your back, and that can tell us very subtle changes in the alignment. So that can be very, very helpful. So although it seems a little bit antiquated to get x-rays, very, very, very helpful. Especially in this patient who says, all my pain is off to the side, it's in the low back, and what they have, if we look at some of the anatomy of normal, architecture of the X-ray, we see on X-rays really well the bony anatomy. we do not see any nerves on the x-ray. And so patients, when they have sciatica, it can be very frustrating because they say, well, where's the pinched nerve? And I say, unfortunately, I can't see the pinched nerve on this view because an x-ray will show us the bony architecture. But sometimes the x-ray can point us off to where there may be degenerative changes that are a little bit more. So looking at this area, the white structure, the squares, are the vertebral bodies on a side view. And the vertebral bodies are very interesting. So they're linked together by what we call a disc space in the front, which is not seen on the x-ray, but actually the absence of it is what we say indirectly is the disc space. So if you think of the disc as the cushion, then the more space that you have between bones, then we'd infer you have a really tall disc there. And over time, what happens is that discs will actually wear. And that's where vast majority of motion comes in from the anterior part of the spine. And the reason we call it anterior, or the front of the spine, is because the nerves, although we can't see them, go through this column. So the nerves are interesting. They're designed in a way where the bone 360 degrees almost covers the nerves and protects the nerves around it. The downside of that is that the nerves have bone almost, or some amount of motion around them. So wear and tear can sometimes cause pressure on the nerves over time. And so although we can't see wear and tear on the nerves, what we can say is, well, if there's a little bit less space in between, let's say, the L4 bone and the L5 bone, then maybe there might be some pinching of the nerves if a patient has sciatica or pain going down the leg. The other things that we can see is the pedicle. So this area is an area that connects the front part of the bone, the vertebral body, to the backside. And the backside, meaning behind the nerves, is a very important joint called the facet joint. And the facet joint is a link for the bones behind. So as the bones connect with a disc space in front of the nerves, in the backside they're linked by a joint called the facet joint, which is a joint just like the knee and the hip in the sense that it has cartilage in between two bones. And so that cartilage also can become thin over time. And the disc space in the cartilage over time having some wear is kind of like the analogy of driving your car. So if you drive your car, the tire will wear thin. The difference is the car probably depends on, is it an electric vehicle? Are you slamming on the brake? Are you accelerating fast? This process especially is largely genetic, meaning this has no real change with whether you're hiking in the morning, surfing in the afternoon, or whether you're more sedentary and reading books more often and laying down or on the hammock. It has almost no difference there. So as active as you are or you're not, the wear is largely genetic. So that hopefully breaks down what an x-ray does for us and how we can see degenerative changes. So if we go back to a little bit more basic anatomy here, the lumbar spine, especially the low back, where a vast majority of low back pain comes from, although it can come from areas in the sacrum or pelvis, and the one area that I won't touch on is sacroiliac joint pain, which maybe next year's talk we'll do SI joint to think about one more pain generator. But this is a different entity. Vast majority of patients, when they come in with low back pain, have pain in one of these 5 bones. So the 5 bones of the lumbar spine make up the vast majority of motion in our spine. And the reason is above this level, the thoracic spine, which is our rib cage, is very, very stiff. And because our ribs go from the back to the front in the sternum, there's very little motion in that area. So we go from a very flexible neck to a very stiff thoracic spine to a very flexible lumbar spine. And that's why we get so much low back pain, is if you think about mid-back pain, although it can happen, very uncommon. And that's because the mid-back just doesn't have that much motion to begin with. So these 5 bones, vast majority of where the pain can come from is that. The 5 bones are connected by some of the things we talked about. Discs in the front of the nerves, and here we start to see some of the nerves here. So the spinal cord actually ends around T12, and the reason I say that is spinal cord compression causes really different symptoms than nerve compression in the lumbar spine. Once the spinal cord ends, it becomes a term that we call cauda equina, and that's Latin for horse's tail. So it really becomes a horse's tail. So it's a bunch of spaghetti nerves, basically, that travel together, and that's why it's such a pinpoint type of pain when you have sciatica. It's not the entire nerve or column of nerves that's irritated. It's usually very, very specific part of the cauda equina or the nerve root that gets pinched, and that nerve has a distribution down your leg. And that's why it's a lightning type of pain that's going down a very specific type of way. The spinal cord ends, and then it becomes all these terminal type of nerves. And this is where you can have sciatica. This is, for instance, the right side, and we're looking at a nerve going down between the L 4 and 5 bone, and this is the L5 bone, and this is the sacrum right here. But the other areas outside of sciatica that can cause pain are not only the muscles. So muscle strains are extremely common. So if you're on an airplane and you twist in an unusual way and put your carry-on overhead and feel low back pain, that's usually muscle. That's usually a sprained ligament. That's usually something that all of a sudden had strain as you were trying to lift something or move something. And the areas that get irritated are the ligaments in between the bones in the back. And that usually calms down. You usually take an anti-inflammatory or sometimes a steroid pack, and that'll go down in a week or two maximum. That's usually the muscle and ligaments. Then the other areas where you can have pain is, this is the facet joint, and that can be twisting, because of a lot of the twisting that we feel, it's these joints that twist or allow that motion of twisting, especially as we play golf, especially as we do tennis and surfing and kind of higher activities of demand in terms of the low back. The other areas that sometimes can cause pain is what we call discogenic pain, so pain from the disc itself. Historically, very hard to diagnose. And the reason is we used to do these procedures called discograms, where we'd inject numbing medication or steroid medication in the disc. But then we found studies that show that discograms, putting a needle inside of the disc, is exactly like doing a flat tire for your car. So the disc could actually degenerate really fast. So we stopped doing discograms. It was also very painful. So then instead of taking away the pain, patients would have more pain after a discogram. But we went through that in the 70s and 80s and early 90s, and the vast majority of providers, especially in Southern California, I haven't really found do discograms anymore. But really we were trying to figure out how much of the disc can cause the pain. So although it still can cause the pain, it can be a little bit tough. One thing anecdotally surgeons say is if you feel like you're floating or treading water in the pool or in the ocean and all your pain goes away, that can sometimes point to the disc. And the reason we think that is because that's offloading the disc entirely, is that you take all the gravity off of your spine. Or sometimes you have patients that do an inversion table or with the chiropractic care do traction. And that also kind of takes the load off of your spine. And so then we think, okay, maybe that's discogenic pain, is that if you feel like you're upright and at the end of the day have more pain, but as soon as you lay down or get in the pool, it goes away, could be discogenic. So going back to our kind of anatomy, if we start at the top, a normal disc kind of looks like this. And then over time what happens is the disc loses water content. And once it loses water content, then it becomes a little bit more degenerative. And actually the disc is made up of water and proteins. And the water content loss is the first thing that we see, and that's how the disc becomes less tall or collapses a bit. And as it starts to collapse, it can look at the end of the line down here where you have disc degeneration with osteophyte formation. Osteophyte is just a fancy word for a bone spur. Just like you get a bone spur in your knee and hip, you can get a bone spur down here in your low back. And the reason bone spurs happen usually is the body, unfortunately, if it could, we wouldn't have as many problems in orthopedics. If it could regenerate cartilage, the body would be amazing. But the problem is that we just can't regenerate cartilage. And the disc is a type of cartilage. Then that's the issue, is that the body's very good at making bone. And it thinks that making bone is more cushion, when in fact, obviously, that's just bone spur. And so that's what's happening, is you have these changes when the disc is thin. The other thing that you see is the facet joint can have the same type of changes where it starts to fuse. Now, one thing that's really interesting thing about this process is at the end of the spectrum sometimes, when we see patients, we have x-rays where every single disc in the lumbar spine totally fused. It looks like this. And when we see the patient, they have no back pain at all. They're doing all their activities. And so actually the end of the spectrum of this, when the patient's spine fuses to itself, all the pain can totally go away because all that pathologic motion gets fused to itself, and so it just does a fusion on its own, and there's no more pain. Now, you can feel stiff. Certainly, patients come in and they say, in the morning, my low back feels very, very stiff. It takes me a little bit of time to get up, to get moving, to get out of the house. But once I am, I feel okay. And usually that's what's happened, is you feel comfortable in the position of sleep, wake up, and then your body has to get back to as much motion as you can tolerate. And remember, this is happening over decades, so this isn't overnight anyways. But that's the good news, that I don't want you to think that this cascade is a painful cascade, is a cascade that causes disability. The opposite. Vast majority of the times, once we get to an autofusion of the body, no pain at all. So there's actually hope, I guess. And this is the area, though, that can cause pain, is that if you imagine that if you have a disc that gets narrowed, in the backside where these cauda nerves are, as they exit each level in between one of these opening called a neuroforamen, from the side view, that's where a nerve can get pinched. And so that can cause leg pain or leg weakness from time to time. So the area where this patient had pain is diagnostically, especially the thing that we want to test is the facet. And so the facet, thankfully, is an area that's the area behind the nerves where the bones connect. And this joint with a little bit of cartilage, thankfully, our pain doctors can do an injection in that area. And that injection can be exceptionally helpful diagnostically. And so one thing that's really important to understand is if you've ever been referred to a pain provider, our pain providers in Orange County are really, really excellent. The main reason is to get a diagnosis, is that if that injection in that area works, then we say, okay, now we know where the pain is coming from. It's not necessarily to live your life with injections. That's not it at all. Is that once you have an idea that that's where the pain is generated from, then you work with physical therapy exercise to target that area, to offload that area from time to time, and we can get patients feeling much better. So again, diagnosis is the key. And this injection, especially for facets with twisting motion, hugely helpful. Now, one thing that can happen is a patient goes there and says, I had some relief of symptoms, but not all of it. Well, then we have to just go down the other facet, meaning that in the lumbar spine, there's basically 10 facets, and each of them we have to kind of go trial and error to see which one is causing the most pain. So one of the most common questions that I get is, aren't steroid injections in this area extremely dangerous? Isn't there an accumulation? It can cause thinning of the tendons and the muscles. In the low back, thankfully, we don't see that. In the shoulder, that can be an issue because the rotator cuff is there. In the knee, we can have an issue like that because of cartilage where it loads differently. In the back, thankfully, we don't have that same type of worry. So patients can have a trial and error, multiple areas of the spine with an injection localized without risk of long-term degeneration or accelerated degeneration. So that's the good news about these injections. Okay, so we cured patient number 1, facet pain, injection, back to all activity once they understood kind of what their rate limiting step was with twisting. So this is another patient, extremely active, walks usually 5 to 6 miles, now says, I can't walk more than 3 miles without having to sit down, take a break, and then my legs feel like they can keep up with me. So a lot of leg pain now, which is different than the previous patient who said twisting low back pain. So had physical therapy, had no real change. This is their x-ray down here. This is an AP image, so anterior posterior image. So their right side would be on this, and their left side would be here. Their head would be way up here. These are the ribs coming off. And you can see that from an AP x-ray, they don't have a major scoliosis. Their spine is overall pretty straight. From a side view, what you see is there's osteophytes that are forming. So you see there's connections that we looked at in the illustration between the two bones. There's some areas where maybe the disc is a little bit more narrowed. But overall, it looks like the alignment of the 5 bones down here in the lumbar spine are appropriate. It doesn't look like there's a huge shift, which we'll look at more detail in the next case, I think. But for this case, it looks like there's just some basic wear and tear types of changes, and the patient has a lot of leg pain. So this patient who says, you know, I've tried physical therapy, I still can't get my legs strong, it makes sense to get an MRI. An MRI will help us understand the nerves and where those nerves are pinched. So here, when we look at the nerves, where the disc is having some wear and where those facets are having wear in the back, and this X-ray and MRI on the lateral is the same. So this image from a side view is the same as this image on a side view and this image. The difference between these two MRI cuts is just the sequence of the water, and so basically it lets us know if one area has more fat or less. There's some conditions in the spine where there's extra fat deposition called lipomatosis in the spine, very rare, but that's why we look at a bunch of different types of series and MRIs. Both of them are a side view, so the belly's in the front here, and what you can see is the nerves are actually this gray structure, and this white area in front and this white area in the back, this is cushion. And so the body has what we call cerebrospinal fluid that goes from the brain all the way down the tube, and it usually covers the nerves the entirety of the way, the cerebrospinal fluid. And the body makes this cerebrospinal fluid all the time. And so if you ever had like a patient or yourself has had a spinal tap, this is the fluid they take. They take some of this spinal fluid that goes up and down our brain and spine. Usually it cushions and looks like this, and what I would say the analogy is if this is the 405 and you're in the car and you're traveling down it, as long as you have a nice barrier and cushion, there's no traffic until you get here, and then it looks like there's traffic and you slow down, and then you open back up a little bit behind the vertebral body, And that makes sense because the vertebral body, the bone itself doesn't move. Does that make sense? The bone stays where it is, but the area in between the two bones where there's motion, that's where the wear is. That's where the degeneration is. And that's where you can have wearing out of the disc. That's where you can have the arthritis build up. And so that's exactly where this patient has wear, is they have wear in the joints and they have wear in the disc, and that causes the roadblock of nerves. So now this patient has tried physical therapy. They didn't have a huge relief. They've tried some medications. They didn't have a huge relief. So now, again, we get them to one of our pain providers and we say, listen, I think we need to do a diagnostic injection, but this time we're not going to target the facet. We're going to target the nerves. And so this is a lumbar epidural injection. Epidural injections are extremely common, and what we do them really is for diagnostic reasons first. Now, obviously, therapeutic would be the best, right? It's diagnostic and therapeutic. Is that not only do I want to diagnose your pain, but I want to help you with your pain. So the nice thing would be if you have a diagnostic injection, you say, wow, after 2 days, I feel way better. My legs feel better. I can walk much better. Then we have to say, okay, how long does it last? So then patients are really kind of counseled to do as much activity as possible and see how long it lasts. Vast majority of the time, patients say somewhere between 6 weeks and 3 months, sometimes longer. I've had patients that have an injection and then say, really one injection, and I feel totally back up to it. Probably all of it has to do with how much disease they have. If you have severe disease, the injection maybe covers the nerves for a little bit. The nerves are happy for a little bit. But then if it's really severe, you can imagine the structural changes that you have. The steroid is not taking that away, right? It's not opening up the highway. It's just allowing for some anti-inflammatory effect on the highway so that it feels better. So that's how we do an epidural. And so what they do is go into the spinal canal, and this is the nerve. So if it was pinched, they would cover that steroid and allow that to travel up and down the spine. And thankfully, very low-risk procedure. In and out, meaning you don't have to have an anesthetic, you don't have to be under, and you can have it pretty quickly. And patients can really get a sense of how much these nerves are the pain generator. Because the pain generator is the most important thing, is that patients can have some stenosis, and that stenosis actually isn't driving most of their pain. It may still be that the facet is driving most of their pain. So some patients can have more back pain than leg pain, but they can have some stenosis on their MRI. What we have to figure out is how much are the nerves causing their discomfort. So that can be a great test. So central stenosis, or pinching of the main highway of nerves, is different than having a blockage of the nerve that's coming out, meaning that this would be the main highway, the 405. So if you have a block here, like this patient does on the MRI, this would cause neurogenic claudication, which is one of the most common symptoms. So patients say, I can walk for a certain amount of time, and then I have to sit down. Or I have to constantly bring my knees up to my chest. And what they're doing when they're doing that is actually, if you imagine, if they're bending their spine the opposite way, they open up their canal as much as possible. They open up the space for the nerves. And so momentarily what they're doing is taking the pressure off the spine and opening it themselves. So that's what patients complain of, is usually neurogenic symptoms. Now, patients that have pinched nerve on the exit point of the highway, not the main highway, so it's just, let's say, Jeffrey or University Drive is the one that's pinched, right? It's not going to be the main highway that's blocked, meaning all the cars on the main highway are fine. But if you were taking that exit point, then you're going to slow down. That's exactly how pinched nerves are if it's a sciatic type of distribution. And so that actually can come from the facet also, is that you could have arthritis or a little bit of a bone spur right in this area, causing a exit point to have a flare-up. So central stenosis is different. This is a patient who says, I can walk for 20 minutes, have to take a break, have to constantly flex my legs up. This is a different story. So now, if a patient has all these symptoms, they had an injection, they said, I felt great for 3 months, got another injection. Unfortunately, the second, third, fourth, fifth injections don't last as long. And that's because the nerves, for some reason, have a treatment effect, meaning they get covered with this and they get sensitized. And then the next set of steroids just doesn't have the same lasting effect. They can feel a little bit better. And there are some patients who have 5, 6, 7 injections over the course of 3 years. It's not dangerous, again, as long as we space them out enough. But durability is the big question, right? It has to be durable for me to say that you should continue to try to get these injections. So if we lose the durability, we've tried everything else, and you feel like you can't get the walking back to that level that you were, then we talk about surgery. And this is that 10 to 15% of patients, thankfully, that need a spinal decompression surgery. And it's really a decompression, meaning this is not a patient who's going to have any rods or screws or fusion. It's a decompression, meaning we just want to take the pressure off the nerves as it's going down the highway. And we have a few ways to do it. So now in 2024, we have basically 4 different types of ways. So If you're classically trained in spine surgery, then everything you did was open surgery, meaning you were looking at the nerves and you were saying, we're going to move the muscles off the bone. We're going to take the bone off of the nerves and we're going to take a look at it. And that would be what this is, basically figure C. So this is an axial view, meaning if you cut me in half like this, and then you look at me from a top-down view, this is the image that you would see, meaning belly would be down here, and right side would be here, left side would be over here, and this would be where my back would be. So we make an incision down the mid portion of the back. We open up the muscle on the right and the left, move it away from this area of the bone called the lamina, and then we take off the lamina or the top. So if the water's boiling in the pot, all you have to do is just take the top off. And then once you take the top off, the nerves have all this room to breathe, and then they feel much, much better. So that's called a laminectomy procedure, one of the most common procedures that we do in spine surgery. And patients actually wake up after the surgery and say, wow, my legs feel like almost back to normal. Now, back pain obviously happens after this type of surgery because we move the muscles off. So it takes about 6 weeks for those muscles to heal. So for about 6 weeks, patients have a sense that I had a back surgery. So then we said, okay, well, can we do it without as much muscle disruption? Is we know we have to take the pressure off the nerves, but let's do it without moving so much muscle. And so then we went to mini open approaches, the second one here. So mini open, we did smaller and smaller incisions. We still had to move the muscle, but we did smaller and smaller incisions. And then we did minimally invasive or microscopic surgery where we just put a tube down into the area. If it was a single level, or if it was, imagine, an exit point of the highway, then you could put a tube right over that area and take the bone spur and shave it off, moving the least amount of muscle. And the most important, and I would say the most recent, is endoscopic. So just like patients have shoulder surgery and knee surgery with a camera, now we do this spinal decompression with a camera as well. So the incisions are getting much, much smaller. But at the end of the day, if we look at all four options, all the studies show that the most important thing is decompression of the nerves is what matters. Is that it doesn't matter the size of the incision or how much muscle, is that at 6 weeks, almost all four categories of patients have gotten to the same point if the nerves are free. So the number one goal is getting the nerves free. And so whatever it takes, if surgeons are more comfortable doing one or the other, that's what matters most, is the nerves just have to get relief. And those patients do well regardless of treatment strategy. This is a great picture of endoscopic. So this is one of the things that I've done in the last 6 months, I would say. And this is what I'm most excited about is endoscopic surgery. So it's just like an arthroscope for the knee or for the hip or for the shoulder, is that this is a 3 millimeter incision on one side and a 3 millimeter on the other. And so my left hand holds this camera, and this is a nerve root. And so this is actually only a centimeter wide, and it looks massive. And that's because it's a 4K camera, and the magnification is amazing. And with my other hand, I can use this small micro instrument and take away all the pressure off those nerves. And if we think about muscle dissection or disruption, this is the least amount, is we just put a tube right down through the muscles without cutting any muscle and take the pressure off the bone, working from the inside out. So it's given us a way to take the pressure off the nerve from finally the inside out, meaning working at the nerve and then taking the pressure off that way, rather than going in traditional surgery, what we were always taught, from the outside in, is moving all the structures that are over top the nerves and then taking the pressure off the nerves. But again, the main thing is you have to take the pressure off the nerves. That's the main thing. So if you take the pressure off the nerves, patients do well regardless of which option. But thankfully, we have techniques now that patients almost with endoscopic feel so good, they want to get back to everything within 6 weeks. And we say even then, 6 weeks is needed for the muscles to really feel like they're back to normal. Case 3 and the final one. So this is a patient who has a lot of low back pain, but also has leg symptoms. Interestingly, this patient says that if I lay down, I feel like my back pain totally goes away. And so here, if we look at the x-rays, there's a subtle finding by the red arrow. The AP, the anterior posterior x-ray on the far left, totally normal. There's no scoliosis. Every bone lines up on top of itself. If you look here, you see how this block doesn't line up with this block? This is called a spondylolisthesis. So spondylolisthesis is listhesis or movement of the spine on top of each other. So it's not a slip disc, it's a slip bone. And so the bone is slipping forward. And this happens actually quite common. Up to 30% of patients have this, and sometimes totally asymptomatic, meaning they're diagnosed totally without any symptoms at all. Sometimes patients, though, have a cause for it. And vast majority of the time, it is degenerative, but there's a few different types of slips that can happen over time. So What's happened is this bone, the L4 bone, is slipped forward on the L5 bone, and it looks like somewhere between like a 3-4 millimeter slip. So then what we have to understand is how long has this slip been going on? Most commonly, it's a degenerative slip. It's those facet joints in the disc that have given way, and so the joints have opened up and allowed the bones to slip on top of each other as the motion happens. But what we can see is actually this is probably a little bit more dynamic of a slip, meaning as the patient flexes forward, the bone can go forward even more. And if the patient goes backwards, it maybe reduces a bit. And so this is where if you look at this patient's MRI potentially, it could look a little bit misleading, as it could come back to a normal position when they're laying on their back, and it would not look like they had a slip unless you looked at their x-rays. So when we look at their x-rays, they look like they have a slip of the L4 and 5 bone. And when we look at their MRI, this is the same side view, whereas the belly's in the front here, whereas this is facing each other. This is the belly on this side. And so not only does the bone slip forward, so the L4 bone slips forward on the L5 bone, but also the nerves at that level have a lot of pinching because of that wear and tear. Remember, this type of change, the degenerative spondylolisthesis, or slipping of the bone, happens over decades. This is a slow process, and what the body is trying to do is hold it in a good position. As it does that, there's exceptional wear and tear at this one level. And so this is a one-level problem. This patient has an excellent spinal architecture above, but right here where the slip is, where that lumbar spine has been working so hard, you can see advanced degeneration of that facet, causing the pinching of the nerves here. And so for this patient, the symptoms are a little bit different. They have improvement when they lay on their back, and these are the different types of spondylolisthesis or slips that we have. Isthmic is also one that's relatively common, up to 15% of patients. This is usually a congenital variant, meaning patients are born with an area in the L5 that's a little bit less stable, as our bones are cartilage when we're young, and then they become formal, mature bone. This is an area that just didn't heal. So sometimes we see this also in very high-level athletes. Gymnasts have this type of isthmic spondylolisthesis. Degenerative is the one that I just showed you. This is the most common. Traumatic is when we have injury that causes this, and so we can have a traumatic break of that bone that causes a slip. Pathologic would be a tumor or infection that causes it, and congenital can also be a different type of malformation. And so this is interesting. So we have a few different ways that we can treat this, but basically in this cartoon, what we see is this bone is slipped forward on this one. And by itself, that's not dangerous. So if a patient doesn't have any leg pain, we can watch that type of slip for a long, long time, and patients will almost never get symptomatic. But if they have a pinching of the nerve, that can cause them leg pain. And what's happening is as the bone goes forward, all of that pinching is happening on the nerves at that level. And the axial view, again, this is like if you cut me in half this way and look from the top down, then you would see the nerves having this hypertrophy of the ligamentum. And this ligamentum is a ligament that goes right here in between the bones, and that hypertrophies, meaning it tries to keep your bone in a stable alignment, but that over time can cause some pressure. So the issue is that with this, you have instability. So if you take more bone or architectural kind of pressure off of the spine, you may cause more instability. That's what we worried about classically, is that patients who had a decompression only for this type of procedure, like we talked about a laminectomy, what we worry about as surgeons is, would the slip get worse over time because we took some of that stability away from an already unstable spine. So then we came up with, not only is decompression an option, especially with the minimally invasive technique. So with the minimally invasive techniques, we do the minimal amount of disruption. So that's what's really encouraging, is that these patients that we used to say always need a decompression and fusion at the same time, now we can do less disruption of the tissues. And so maybe that slip won't get worse over time, is we can just do a decompression. But decompression and stabilization or fusion surgery can help the slip. And this is a great kind of before and after picture. So this is an L5S1 spondylolisthesis. You see L5 on the sacrum doesn't line up. And what they've done here is an anterior posterior surgery where there's a cage that goes in the disc space, and then the screws back that up from the posterior aspect. And there's a huge alignment that's gained in making the bones completely stable. So this is an exceptionally common surgery, and it does two things. It not only takes the pressure off the nerves as we get the alignment better, but it gets the spine in a better alignment. So patients do really well with this spine surgery as well. The other thing that's really cool is that this is, again, that axial image, so belly is all in the front. And then this is a kidney right here, and this is a kidney, and this is the psoas muscle. So this is actually the fillet. If you eat steak, this muscle is right next to the spine. And this muscle is really important for us because we've understood that this muscle has all of those exit points of nerves around it. And with surgery now, what we can do is understand where those nerves are in the fillet. So we understand where those nerves are so we can access the side of the spine like we never could before. In the last 15 years, what we've been able to do is realign patients' slips of the bone with the most minimally invasive techniques, meaning patients are really home within a day or two with minimal disruption. And that's really understanding the muscle architecture and also some of the advances in technology. But now this is what I do. So we used to have to put patients to get through the fillet on their side. So we'd say, okay, so we're going to do a left-sided approach. First, we'll put you on your right side. We'll do an approach, and then we'll do a second stage where we put you on your stomach and do the surgery from the back. But now we can do all of this in one position. So this is, for instance, how we do it. We access the front of the spine, meaning front of the nerves, by moving the abdominal muscles a bit and the retroperineum, and we go through the fillet, if you will, without cutting it, and get access to the disc to realign patients. And so that's a really powerful technique, especially because this is now a single-stage procedure, where even now, in some areas, it's a two-stage procedure. And I don't think it makes sense. 2 stages is 2 times the anesthetic, and so that's 2 times the recovery. And so these things have now allowed us to provide really fast recovery for patients that might have had, 2 weeks in the hospital or so. Okay, I think that's it. That's a lot to cover, and I want to thank you for your patience. I spoke a lot, but please take it away. Thank you so much.
Thank you. We will open it up for questions now.
Yeah, I've been a chiropractor for 40 years, and now I specialize in seniors. And I'm amazed at what you're able to do now. That's really great. I have a question, though. In Europe, they were making fake discs now. Are there any ready for the United States so that you have to put the screws? Because as people age, they're going to get osteoporosis. And if you don't allow the natural movement, you end up accelerating the rate of osteoporosis. So it's like putting screws in Swiss cheese, versus a block of cheddar. So are there going to be any of those available soon? Because there were about 3 and they all failed.
Great question, and very knowledgeable question. So total disc arthroplasty, or motion-preserving surgery for the lumbar spine, in Europe caught on much more than the U.S. Even now, there are certain centers, and actually Cedars is one of them, but also the disc group here in Orange County, they will perform disc arthroplasty. The long-term outcomes of disc arthroplasty are not as well studied as fusion. And so that's why fusion has probably taken more traction when patients need it. I think the big thing to understand is fusion is now reserved for really patients that need it, meaning more and more, if patients have the nerve symptoms and stenosis, then we do just decompression, meaning we try not to put any rods and screws in. The other thing that's changed quite a bit is screws now, we can understand each bone's health, meaning everyone's probably familiar with DEXA scans. Now we have DEXA scans for every bone of the spine. So if we're planning a major surgery, we know which bone is a little bit weaker and which one's stronger, so we'll treat it accordingly.
What do you do with the older patients that are having failure from surgery 20 years ago?
So our revision strategies, because we understand bone health, are better than ever.
Are you able to take them out?
Yep.
I've read quite a bit about Stanford, where they've had quite a bit of research in regenerating the discs. What can you comment on that?
I wish I had more to comment. Hopefully in the next 10 years we'll have a lot more. Right now we're still trying to understand the utility of stem cells, PRP injections, plasma-rich platelet. But the problem is all of it is very investigational, is we don't have great science to understand which will cause regeneration of the disc.
So my mother had spinal stenosis, a very severe case. She just had a laminectomy from L2 down to S1 and fusion. And if this is genetic, I'm a little concerned about myself. But if I was to need it, are you saying you could go in through the front, like the stomach, And wow. And my mother has an 8-inch
Right.
opening, and she just had this in December, but it wasn't through UCI, it was through Kaiser, and they still do the old-fashioned open it up, and I was so sad for her. It's literally taken her 3 months to recover versus the 6 weeks you're talking about. And she has, of course, like a cage and multiple screws. So I'm hoping I have a much different experience.
Definitely. So every patient's spine and how much stenosis they have really dictates how much. I think it goes back to the main point of you have to take the pressure off the nerves, and sometimes you have to do a realignment surgery. Now what we're understanding is not every patient needs a realignment. So we really restrict all these rods and screws for patients that need it. Is that if patients come in with largely leg pain and stenosis symptoms, it's really about taking the pressure off the nerves. And if you have to take that much pressure off that you're causing the spine to be unstable, then we talk to patients about instrumentation.
I was thinking about that epidural injection and wonder what kind of qualifications a person would have to where I should feel comfortable them sticking a needle in my spine.
The one thing I will say is the UCI pain management service is amazing. But even in the community here, there's excellent pain providers. Most of them you'll see are either boarded in anesthesiology, so they're anesthesiologists by training. They do epidurals routinely. Or physical medicine rehab doctors or physiatrists. They're trained in that as well. Or they have a pain management subspecialty, a fellowship. They may be qualified. So those are the big three, is either a pain fellowship, anesthesiology, or physiatry.
What advice do you have for someone who has osteoporosis like myself? I'm an active person, but besides taking the RX too, what else can I do?
So are you on a bone building agent now?
Fosamax, yes.
Wonderful. So now, the treatment for osteoporosis with these bone building drugs is better than ever. We used to say that these types of bisphosphonates, we would keep patients on them lifelong, but we understood their side effect profile. So now we'll do a holiday after a certain amount of years and build it up. But outside of that, calcium, vitamin D, and the drugs, it's really weight-bearing exercises. So as much as you can do for the body to have some weight on it. Meaning, even if you were to walk around with, sometimes you'll see ankle weights or like a 5-pound weight in each hand. That's a huge amount of difference for your spine. Yeah.
For that gentleman over there, I just had an epidural this afternoon, and I'm still here. I had laminectomy in 1997, and now I have severe sciatica, and I'm trying to avoid surgery. I've been told that perhaps I need to have fusion. And I'm wondering if going to physical therapy, because anything I do just seems to make it worse. So I don't want to make it worse. I mean, right now my foot is numb, my whole back hurts. I can draw the nerve,
Right.
But I'm wondering what should I do because I don't want to have another surgery.
So even in this case, so the issue you bring up is a really good one that I didn't fully touch on, is if you have a laminectomy procedure, so one of these 4 types of techniques to take the pressure off the nerve, because it's a non-fusion surgery, there's still motion in the spine. So although we take some of the arthritis off, some of the lamina that's pinching the nerves, the arthritis will continue to build. So over time, a patient who had great relief for some amount of time may then have arthritis build up because it's a non-fusion surgery and pinch certain nerves. Now, the big thing diagnostically would be to figure out which nerves are being pinched, especially when patients say that it's one nerve, I can draw it out down the leg. Then we can consider a decompression again of that same nerve. So it's not revision surgery now has better outcomes than it ever has. Meaning that a patient, that we all fear is you had one surgery that led to another surgery that led to another surgery. That's thankfully going away now because we finally understand which patients need what type of surgery, number one, and which patients can have that type of surgery without having adjacent segment disease, which I think you mentioned is the level above or below a fusion could have extra strain, and so that's called the adjacent segment.
Well, I had a knee replacement in December, And I'm, you know, what did Steve Lopez call it? Managing the decline. And I just think I just can't do this again.
Right.
I have things to do, not besides go see the lovely doctor.
Yeah.
Hi, well, thanks for being here, number one.
Of course.
Appreciate it.
Yeah.
If you have a fusion with, say, the 4 and 5, what does that do to the upper? Does it leave,
Great
does it cause more, can it cause more stress on that?
Great question. So, especially here, if we think about a patient who has a spondylolisthesis or a slip of bones, this patient, if they have a fusion, that fusion has to be the appropriate alignment, meaning what we have battled in spine surgery is flat back deformity, meaning that the scoliosis and the deformities that we're seeing are created by the surgeon, meaning we're not putting that spine in the appropriate alignment. So your question about what happens to the level above and below has more to do now with understanding what the alignment that was gained, basically. So now, basically, in these 5 bones, L4, L5, and S1, what we understood, we know we have to hit certain parameters. So we know exactly the number we have to dial in that level for this curve. So the risk of adjacent segment degeneration from excessive wear is now lower than it's ever been.
But it's still there. I mean, it's still, but not to an extent it's going to cause problems.
As long as we align the spine into the appropriate alignment.
So it depends on the surgeon, you're saying, then, pretty much.
Technique, yeah.
Okay, got it.
Quick question over here. Right.
Yeah.
Now that we know that most back pain is caused by genetics, thanks mom and dad,
Right.
if someone comes in to see you and has their genome decoded, do you ever look at that, look for variants and SNPs and stuff like that? And if so, does it influence kind of what you look for in any way?
It's a great question. So there's actually very few diseases in the spine that we know with that certainty that are dominant in terms of their genetics. And vast majority of them, thankfully, so far, ankylosing spondylitis, diffuse idiopathic skeletal hyperostosis, both of these are just fancy words for a stiff spine, is that the spine becomes like a bamboo shoot of stiffness, doesn't need surgery. But we are finally getting there.
Be outside of your area of expertise, since you already blamed our parents and we are aging. What can we do now so we don't have to see you?
So motion is the key, really. So if we think about it, motion is the key. And there's, I think, 3 exercises that I encourage everyone to do, including myself. So it's yoga, Pilates, and foam rolling on your back. And the foam rolling on your back is the most recent iteration of physical therapy at home for your back. And the reason is life, spine surgeons joke, is a kyphosing process. So you just start to go forward over time. Everyone does. What you want to do is extend your back as much as possible. So if you take a foam roller and put it right over the middle of your back and try to roll over that a few times a day, that probably extends our back better than anything else can.
What's a foam roll?
Wow.
It's just like it's like a PVC, but it's bigger and softer. It's like a log. It's like a foam log. Amazon, CVS, Walgreens. Amazon. Yeah, there's some that are like textured. You just want like
You
a.
don't want the one that looks like a tire.
Yeah.
It seems now when I travel that all the hotels want to give you a pillow top or what I call a marshmallow bed, and I can't sleep on those.
Yeah.
I get on the floor and sleep, literally.
Yeah.
You know, my wife and kids are like, he's a freak, you know, but I'm fine.
Yeah.
But if I sleep on one of those beds, I'll be, you know, hurting. And I wonder, is this, when I get on the floor, I'm fine. And to do the yoga, stretching, every day I have to do it. You know, if I go 3 or 4 days without it, I'm in trouble.
Right.
Is this slip at 4 and 5?
We need an X-ray to know what the alignment looks like. But the other thing you bring up, which is a really good point, is patients often ask me, what pillow should I be using? What type of mattress should I have?
I'll come to you
And what type of shoes should I wear for the chain as it goes from the feet all the way up? There's actually no evidence that any of that will change the architecture. And that's why genetics is the main part of it. But it really depends on what you feel comfortable with. You know, like what I feel worst about is when patients spend thousands and thousands of dollars behind some of this stuff, which can be a little bit gimmicky. and then you really have no change. It really depends on what you feel is most comfortable for you.
People would wake up with back pain in the morning, but if they listen, walk around, it goes away, whatever. So is there a way to prevent that back pain from happening to begin with?
That's a great question. So usually we relate that back pain, although it can be multiple types of reasons or etiologies, to stiffness, meaning that you got comfortable in one position, you stayed there, and then once the patient has to get up and start their day, that's a lot for the back to have to do all at once. So it takes a while to get that motion back.
Just to answer that, Tai Chi stick, the Vietnamese longevity stick, is excellent. It's even better than yoga because it keeps you moving. And also pool exercises where you're using ankle weights and the pool noodles, and you're just hanging and moving in all directions, including extension.
Aquatherapy,
But
yeah.
my question to you is, in some places they were using bone graft from, the ilium. Are they doing fusions with that so you don't have loose screws?
Great question. So non-instrument infusions, meaning without rods and screws, is still performed sometimes. But we've gotten away from harvesting vast majority of bone graft from the ilium or the hip crest, and that's because it overall is a pretty...
It sounds painful.
It's a very
It was
painful
very
procedure.
painful.
Yeah.
And they don't use cadaver bone anymore?
We do.
Yeah.
Yeah.
Okay. All right, yeah, but
Yeah.
Vietnamese longevity stick.
Thank you. I asked this question, it's more like a diagnosis, but I'm asking it maybe other people have the same symptom. And I noticed one of your slides you had the term weakness. I have no pain at all, but I've recently had weakness. If I squat totally to the floor, I can't get up without using my arms. And I know my legs are stronger than that. So I'm thinking it's a nerve issue that's not firing or something. Should I see a doctor about that? There's zero pain and I can play golf and I can do everything else. Just a question.
Great question. So painless weakness is usually not the spine. Is the spine, these nerves, when they get pinched, it's pain associated with weakness. And so painless weakness, usually I get you to see a neurologist to see the nerves outside of the spine and how they're behaving and functioning.
Back there.
Do you ever see hip issues like impingement, hip impingement affecting and delivering pain in the spine? Do you see that frequently?
So back-hip syndrome is very complex, and back-hip syndrome is it can be pain generators from all over, sacroiliac joint, hip impingement, pubic symphysis. So yes, we do. A lot of it is diagnostic injections to see how much it's the hip or the ball and socket joint and how much of it is the back. But yes, great question.
And that would be done by epidural or
by
an injection?
Injection one at a time. So we would inject areas of the back and see how that does. And if it has no relief, then we say, okay, maybe it's more of the hip. Got it. Or vice versa, depending on.
Okay. I had spondylolisthesis diagnosed in 2001. So here we are 23 years later. I do Pilates twice a week, yoga, and that looks just like my x-ray. So my question is, am I suddenly going to get worse?
Great question. Probably not. So the good thing is that vast majority of patients with this spondylolisthesis, if they can, if their nerves, number one, are not very pinched, their alignment is well tolerated, and their muscles are really strong, it's usually a static slip, meaning it's not dynamic and they're not going to move suddenly and make anything worse. The other thing to remember is this is not a spinal cord level, because at T12 the spinal cord ends, and so patients can never have a catastrophic weakness of their legs in the low back. Now, thankfully, usually not. The only thing that can cause a catastrophic weakness is bowel and bladder incontinence, meaning I can't feel my perineal area and I have incontinence all of a sudden of my bladder and bowel. That would be a red flag from the low back. And numbness by itself is usually not dangerous. That's the other thing, is we'll all go through episodes or times when our foot or our hands are numb. By itself, not dangerous.
This is our last question.
Thank you. You said that you've been doing endoscopic surgery for the last 6 months or 9 months. Is that the cutting edge today, or?
I would think so, yeah. In spine surgery for sure. Because it's allowed us visualization into the nerves like we never have seen before. with the smallest incisions in the spine.
Right, but I've heard of, I think I've read, they make a difference between endoscopic surgery and surgery using robots. Is that?
True. Yeah, so robots right now in spine surgery largely are really only used to place pedicle screws or the screws in the spine.
Okay.
Is that they target the bone really well.
Right. Okay, thank you very much, because I see your hands are.
Yeah, right.
Thank you, Dr. Hashmi.
Thank you, guys.
So this will conclude our season. We'll see you again in September. Look for our announcements. And these episodes are recorded, so if you have friends who couldn't come tonight, tell them to go online and they can see these free. The videos are free. So go forward.